morning, good afternoon, and good evening to our wonderful speakers, chairs, and the audiences of ACNS webinars in different parts of the world. We are back again with another session of very interesting lectures for you in this inaugural session of the month of November. The speaker for the first session of today is our honored guest from Czech Republic, Professor Vladimir Venice. Professor Venice has held the position of the head of neurosurgery in the Central Military Hospital, Prague, and chairman of the Department of Neurosurgery in the First Medical School, Postgraduate School of Medicine, Charles University. He was the past vice president of the European Association of Neurosurgical Societies till 2007 and the chairman of the training committee of the ANS as well as the president of the ANS. He also heads the neuroanatomy committee of the WFNS along with Professor Imad Kannan. He is an invited faculty to various workshops and conferences organized all around the world. His literary contribution sums up in scores of publications in various international journals as well as book chapters. We are extremely thankful to him for accepting our invitation to be a speaker at our webinars, and today he'll be talking about posterior fossa meningiomas. The speaker for the second session of today is our honored guest from Japan, Professor Masanobu Suda. Professor Suda is the professor in the Department of Emergency and Critical Care Medicine, Aichi Medical University. He is also the director of Disaster Medical Research Center, Aichi Medical University, Japan. He is an integral part of the Japanese Society of Emergency Medicine and Japanese Association for Trauma Surgery. He is a noted author with several publications in various peer-reviewed journals and is also a recipient of several awards and honors for his outstanding contribution towards neurosurgery. We are extremely honored and thankful to him for accepting our invitation to speak at our webinars, and he'll be talking about trauma care systems and helicopter emergency medicine in Japan. The chair for the first session of today is an honored guest and senior faculty from Japan, Professor Takayuki Hara. Professor Hara is a director in the Department of Neurosurgery, Toranomon Hospital, Tokyo, Japan. He is an active member of the Japanese Neurosurgical Society as well as many other international societies. He is an active researcher and was an author included in the ATTACH-2 trial for intracerebral hematomas. We are extremely thankful to Professor Hara for accepting our invitation to chair the session of Professor Venice today. The chair for the second session of today is our honored guest and senior faculty from India, Professor Deepak Gupta. Professor Gupta is a professor and consultant neurosurgeon at the Department of Neurosurgery, All India Institute of Medical Science and associated JP and Apex Trauma Center, New Delhi, India. He is also the chair, Pediatric Neurosurgery Fellowship Program and Services. His research interests are focused upon neuro and spinal trauma as well as pediatric neurosurgery. He is a core committee inventor of the International Head Injury Guidelines as well as core committee member of the International Consensus Guidelines for Decompressive Craniectomy in Traumatic Brain Injury. He has received several awards and honors for his outstanding contribution towards neurosurgery. We are extremely honored to have him today to chair the session of Professor Masanobu Suda. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers and chairs and the distinguished audiences to this online platform of ACNS webinars. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this virtual podium to our first chair, Professor Takayuki Hara.
Thank you, Dr. Raja, to give me a chance to chair this great session. Today's first speaker is a great neurosurgeon from Czech Republic, and Professor Vladimir Venice is quite famous neurosurgeon. Also, I know him, and most of the neurosurgeons in the world know his name and his academic career. And today, he will talk about posterior fossa meningioma, and I also, and all of the audience from the world are looking forward to taking a lecture from him. So thank you. Professor Venice, please start your lecture. Thank you.
Thanks for kind invitation. It's always a pleasure to be part of ACNS teaching group, and it's a great honor. So let me please talk about the posterior fossa meningiomas. I have nothing to disclose. As I have said, I'm always glad to be with ACNS and be part of their activities. The outline of the lecture is at first some general remarks, then we shall go from petroclival to sinus-sinus junction, dislocation, then the pineal region and straight sinus, CC junction, clivus, and jugular foramen will be the next. Then I shall talk a bit about the meningioma taxonomy, which really is a difficult, very difficult topic, and of course, conclusion. Should the time allow, I can introduce you to my country, which is probably a little exotic for you. So over the past 15 years, we have had a total of 1,650 meningiomas. Of them, 750 were skull base, 120 spinal, and posterior fossa were 230 meningiomas, which is 14% of total. So this is probably the regular percentage of posterior fossa meningiomas. What I have learned checking out figures is that mortality in skull-base meningiomas exists. We hear lots of lectures where there is zero mortality. That's almost impossible. I'm always hesitant about seeing all these statistics with zero mortality. There is also morbidity, some 2–4%, and minor and temporal morbidity constitute some another 5 to 8%. And this number decrease going posteriorly, increase going anteriorly and medially towards the clivus in the posterior fossa. The petroclival meningiomas still constitute the highest morbidity mortality in neurosurgery. There are three major classification systems. First was set by Yashargil, and he treated the posterior fossa very modestly with CP angle, petroclival or clival, and CC junction. There was it. Almefti's classification is perfect considering the skull base. He treats the CP angle very nicely in relation to the internal meatus. And he has clival and petroclival, of course, jugular foramen, a specific groove, which is also very sensible and logical, and then of dividing foramen magnum meningiomas into three groups. Dieva extended the classification posteriorly and towards the, let's say, convexity of the cerebellum. So he has this very specific group of sinus junction meningiomas at the junction of sigmoid and transverse sinus, and then along the rectus sinus going to the pineal region. So I will more or less go along Dieva's classification. But let me please start with what I have learned about the meningioma. It is the arachnoid membrane which is paramount and which is to be taught, all the system and everything. See these two olfactory groove meningiomas, exactly the same in size, exactly the same in location. The difference is the edema, which is unilateral in this case and bilateral in this case, and the position of the anterior cerebral arteries, which are shifted to the side in the first case and which are in the midline in the second case. What does it mean? It means that on the left side, the brain and all other structures like olfactory nerves are covered by 3 layers of arachnoid. Thus you have very nice plane of dissection and very good chance of preserving of olfactory nerve. It is much more difficult in the case with midline anterior cerebrals, because then both frontal lobes and olfactory nerves are covered by one single layer of arachnoid only. We have studied that in our series and see that in unilateral approach with some asymmetric position of olfactory meningioma, we were able to preserve the opposite side, olfactory nerve, in 77%. And we were able to preserve normosmia in 50% of them and hyposmia in 30% of these cases. So this is important, and this is applicable to all the other meningiomas whenever you meet them. We published this tuberculum cellae meningioma with EANS skull base group, and we've treated arachnoid very carefully there. See on one of our specimens what it looks like. The firm structure is formed by arachnoid on the outer layer, which is important. Inner, the systems are divided less more precisely. The only structure of the skull base is the Lillienquist membrane, which really defines the posterior and anterior fossa or middle fossa. See here, we are looking from above, from below, along the stem of the basilar artery. These are the P1s, and you see that the premedullary and interpeduncular systems are not well defined in this image. These are only trabecules, but Lillienquist membrane is a very firm structure, and of course the outer membrane is impenetrable. We published this how to dissect the skull base in a single article. And considering the diagnostics, the T1 with Gado, this is the image for radiologists. This is not for neurosurgeons. For neurosurgeons, it's T2. T2 image is paramount. What you can find here, you can find the origin of the tumor according to these radial lines. You can guess that this part will be firm and this part will be soft part of the tumor. You will see the dissection plane and you see the edema, so you can expect adhesive growth in this region. And you can find other structures like 7 and 8 which are distal from the tumor. So these are important. Then, especially in posterior fossa, as the tumors grow along the sinuses, you need to get some information from the angio, MR angio, CT angio, or even regular angiography, which is not anymore done frequently. See this tumor in sinuses junction. The transverse sinus is not developed at all. You would guess that it will be easy for radical resection because all blood flows to the opposite side, which is not true. And the reason for partial resection was the vein of Labbé, which inserted the sigmoid sinus, which is patent here, distal to the tumor. So only partial resection. The opposite case. Again, junction of the sinuses, the tumor, the only transverse sinus is on the affected side, so you would get that you will have to leave the remnant there, not to harm the sinus. Not true. Very nice symptom to resection. Straight sinus, another very important question. In such a tumor, you would expect that the sinus is occluded, but it's always good to have it proved, and then you can do the radical resection. Actually, if we divide the tumors, the meningiomas, they are like a transitional zone. They are transiting from one group to the other. They are overlapping. So it's a continuum with the mother of all in cavernous sinus. And if you go along the tentorium CP angle, then you get to the petrocliver tumors. Then you go along the sinuses to the junction, and yet again back along the transverse sinus, and you will end up in pineal region. The only blind are the spinal ones. Otherwise, it's really a continuum of tumors, which is given by the venous system composition, because the tumors grow from arachnoid cup cells, and these are most densely located along the sinuses. And this is the U form of sphenoparietal sinus, superior petrosal sinus, and of course cavernous sinus. It's the place of the most difficult meningiomas and the location which is rather frequent. So here there are convexity posterior fossa tumors, there are tentorial posterior fossa tumors, CP angle tumors. You see that the tumor origin is posterior to the Syst nerve. So those are not petroclival, despite the fact that lots of the tumor is growing in petroclival region. And these are true petroclival meningiomas. See that here the tumor origin is anterior to the Syst nerve, so it's already petroclival. Rectus and spinal tumors, not really that frequent, but rather difficult sometimes. And CC junction, just to complete the overview. And find these tumors along the superior petrosal sinus, which now will be the topic of my lecture first. From PC tumors, petroclival, then you go to CPA, and then you get to the sinus junction. But there are tumors which are overlapping all three of these locations. So this is really a continuum of the tumor from the junction forward to the petroclival area. This is the work of the McDermott group from UCSF, a very nice classification of the tumors into posterior, which are at the junction, then middle, which are between the 7th and 5th, and anterior, which are actually in front of the 6th, and only these are the true petroclival tumors, but they really overlap each other. You may divide the tumors, at least in this location, more precisely. This is from Japanese group. They divided the tumors into 4 groups according to the blood supply, which is very logical and very sensible, because there you only can say that this is true origin, but that really means to do the angiography. These are not really petroclival tumors, these are sphenopetroclival tumors. This is one of our dissections, and again we are getting back to the arachnoid. See that we are looking from below. See that the 5th nerve is covered by the outer layer of the arachnoid posteriorly to the nerve, in the distal region, in the direction to the 7th and 8th. But as soon as you go above the tumor, this arachnoid gets to the brainstem and thins out very much. So this is the difficult place of resection, difficult location, because there is not enough arachnoid to cover the brainstem and especially the 6th nerve, which is a very troublesome nerve. Going higher up, we are ending up in ambient system. You see the 4th, and should the tumor grow from tentorial edge, which I will show you very shortly, then you really may harm the 4th nerve, which fortunately doesn't have many consequences, but you should remain within the arachnoid of the ambient system. You shouldn't enter the basal system. Again, another in CP angle, how the arachnoid turns around the 7th and 8th, around the 5th and around the 9th and 11th. All these nerves have a very short distance where they are not covered as they leave the skull. They are for their its own arachnoid only, which is very thin, but still allows for the plane of dissection and still allows you to preserve these nerves. But it's always better to be within this arachnoid, which is rather thick and compact. Which systems do we talk about? In this region, we are talking ambient system, of course, cerebropontine and cerebromedullary, then crural system, and peduncular system for petroclival tumors. Going higher up along the ambient system, we get to the quadrigeminal system and to the velum interpositum, which usually is forgotten when talking about systems. And here already is seen very nice approach, which would be supracerebral infratentorial, because there you can reach all this region, as I will show you shortly. So this is the most important route with supracerebral infratentorial, not these 3 ones, which direct you to the pineal region only. This allows you much more. So here we have one of the tumors, which is on the tentorial edge, and see that as soon as we get to the tumor, we just decompress, devascularize and decompress the tumor. The surface of the tumor while dissecting should be rough and grainy, not smooth. As soon as the surface of the meningioma is smooth and shiny, it means that it's still covered by the arachnoid. So through this, try to dissect the arachnoid, restrict your coagulation, because then you will lose the plane of dissection. This is the tumor origin. There is already only the very small remnant on tentorium, and as soon as you dissect this, you achieve very nice Simpson 1 resection. And you see that the basal system were never ever entered, only the lower part of ambient system. This is the brainstem, obviously. So this is after. This is another one. This is already CP angle tumor. And again, the rough and grainy surface of the tumors means that we are outside the arachnoid membrane. We are at the internal acousticus meatus. This is the 7th, 8th, with tumor remnants within the meatus. And this is the troublesome nerve, the 6th, which should be preserved at all costs, because the 6th nerve palsy is lifelong and very debilitating for the patients. It's virtually a loss of an eye. This is the 5th at the end of surgery. A little more difficult tumor, which is through petroclival, and it's reaching even posteriorly to the optic chiasm. There are 4 steps resecting this tumor via supra-infra approach. First, the tumor along the trousal sinus is detached and devascularized. Then the tentorium is open in a triangular fashion with this cut ending just posteriorly to the 4th nerve entry into the cavernous sinus. And then the subtemporal and interpeduncular parts of the tumors are dissected. So this is the 7th, 8th, ICA, and 5th nerve. Next is the 5th and 6th nerve. Then you get the 4th nerve. Still, I admit that I still do not know how to preserve this nerve properly. And here you see the arachnoid of the interpeduncular system, which is very thin and not really compact. Here we get already into the interpeduncular system, and we are looking to the opposite side. This is the opposite side posterior clinoid process, 2 on the opposite side, optic tract on the opposite side, and pituitary stalk. This is ipsilateral posterior clinoid process, P2, superior cerebral artery, which is running towards us, and of course the third nerve, which is always between the superior cerebral artery and posterior cerebral artery. This is the basilar artery. And this is the triangle tentorial cut. And this is the whole approach you need just above the cerebellum. This is post-op, of course, the piece in the sinus is left behind for future eventual gamma knife surgery. This is a more formidable tumor. It's within the petrosal sinus, within the cavernous sinus, subtemporal. There is a large portion in petroclival region. We did this with an exoscope, which is a little more comfortable than microscope, especially with supra-infra. Only the horizontal axis is difficult for you. The assistant must lead your hands into the wound because you are looking in the other direction. And this is what it looks like. This is the tentorium already cut. And we are getting very soon above the tumor and in front of the tumor to get all the necessary structures visible. This is the medial part of the tumor, superior cerebral artery. Here is the fifth. And you just dissect the tumor from all the regions which are accessible. This is the fifth nerve, which was completely embedded in the tumor. We are going forward and upwards, getting the subtemporal part of the tumor, and this is the third nerve. And you see that the tumor extended really in front of the third nerve, but it never penetrated the Lilienquist membrane. Lilienquist membrane is really a good wall and good frontier for almost all the tumors. Somehow it's impenetrable. This is the Lilienquist membrane, this is the third, this is the uncus, all seen from above the cerebellum, which is over here. And now we are dissecting. You see the fourth nerve is severed. I admit that that's a mysterious nerve for me to preserve. And now I always actively seek for the sixth, which is over here, being stimulated. So we are in an interpeduncle and cerebropontine system. And this is the fifth nerve and final step, dissected free from the part of the tumor which is above the nerve, and this part along the cavernous sinus was left behind. So this is what we achieved. You see that the tumor is resected very nicely with the remaining piece of the tumor within the cavernous sinus, and which is suitable for radiosurgery. We have the intra-OPMR, and we can immediately plan for radiosurgery, so we know that the resection is sufficient to allow for further gamma knife treatment immediately in the OR. Another of these petroclival tumors, this is just to show how to cut the tentorium. It's always good to check for all those venous lacunes and venous channels within the tentorium. The bleeding may be really tremendous and very troublesome to control, so check the tentorium for any venous drainage, because it really is troublesome, but once it's free, you just cut it. And the best advantage of this maneuver is that you very early on in surgery get above and in front of the tumor, and you see the plane of dissection between the brainstem, which is here, and the tumor, which is here. This is the superior cerebral artery. So very early on, you will find out whether you will be able to resect the tumor totally or not. It's not a tumor like that before and after. Then the supracerebral infratentorial can be combined in this rather large, very large, long attachment to the clival tumor. This is after surgery. And let's see the video. We are starting supra-infra, and this is the tumor covered by the outer layer of the arachnoid. It means that the tumor is within the prepontine and premedullary system. This is already the mesencephalon, and you see that we start our resection high above, then we get lower to the retrosic approach. This is 7th, 8th, and still the tumor is underneath. This is 9th and 11th, and the tumor goes even lower than this. And only when all these three approaches, which is virtually far lateral approach, are done, then the main bulk of the tumor comes into view, and then the tumor can be resected by using all these three approaches. This is just to show that the basilar artery, ICA, and even the sixth nerve from the side are covered by the outer layer of arachnoid and thus can be preserved. These are the remnants when you cannot resect the tumor completely, when the plane of dissection between the brainstem and the tumor is non-existent. So we leave the piece behind rather thicker than thinner, because if you coagulate on thin layer, you usually coagulate the brainstem vessels. This remnant remained stable for 6 years. This remnant grew, so we used gamma knife for controlling the growth. These surgeries are not without risk, is documented by this patient. You see rather straightforward CP angle tumor. 3 days after surgery, thalamic bleeding on the other side, and the patient unfortunately died. It's not only humans who have petroclival meningiomas. Here you see the dog with a rather large petroclival meningiomas. Here supra-infra is impossible, so it's combination with in retrosic and far lateral. This is the lateral side of the brainstem in a dog, and this is the owner of the tumor happy the day after. The very similar tumor. Somehow dogs have more tumors in the posterior fossa than in the supratentorial compartment. We have published the versatility of the supra-infra approach with colleagues from several departments, and it's really very, very flexible approach, and approach to almost anything which is located in the upper CP angle and pineal region, and even in thalamus. Let's go to the midline and superior tumor. Those will be the pineal, rectus sinus, and torcular tumors, so coming from posterior, which are not really easy, but not really that difficult, to anterior rectus sinus. Of course, the question is the patency of the sinus. Then along the tentorial edge, two pineal tumors, and here the lesions which are getting into several compartments, nearly down to the fourth ventricle, then the pineal region. And this is the piece of the tumor which is within the velum interpositum, the forgotten velum interpositum. This is the view you get once you get to the pineal region, both internal veins, both Rosenthal veins, vein of Galen, and you find a lot. We use this approach rather frequently. There is a series of more than 175 patients. It's unilateral in almost exclusively. There was one case of a bilateral approach. I will show it actually. Sitting position, we are not afraid of sitting positions. We have good anesthesiologists. CSF drainage at the beginning, usually lumbar, because the craniotomy is restricted. You do not reach the CSF spaces at the beginning of surgery, like systema magna. So we use the lumbar, and it's really just for the beginning of surgery to allow the cerebral hemisphere to fall down. Is a microscope, which is rather ergonomic, but you need to have a longer arms, or exoscope, which is even more ergonomic, but then the horizontal axis is somewhat distorted. You do not get about the vertical, you are accustomed from the microscope. This is the craniotomy, transverse sinus. After the opening and after the draining of some 20-30 cc, you immediately have your space to enter the region. So he is one of the meningiomas before and after. We are talking these systems, we are talking the quadrigeminal system, we are talking the upper part of ambient system, and we are talking velum interpositum. Let's see one of these meningiomas, which really was located in pineal region and in the velum interpositum. This is a more difficult region. Actually, this was one of the very difficult cases for me. You see, this is in velum interpositum. The tumor grows subtemporally. It's not really compact tumor, so it was rather difficult. Let's see the video. So this is the beginning on the right side. You open the tentorium to reach the subtemporal globule of the tumor. This is a little trick that you may put a stitch even into the tentorium and use it as a tackling suture, and it gives you some more space, any millimeter which you get upwards is very helpful here. And this trick with tackling the tentorium gives you some 3-4 millimeters of space. So here we are releasing the subtemporal part of the tumor. And this tumor was very aggressive. All the vessels were really within the tumor capsule. And of course, in this region, you must preserve all the veins and all the arteries. This is the corpus callosum in front and above the tumor. And tumor is slowly decreased and small resected from the right side first. Then we are getting to the left side. This is already the pineal region. This is the vein of Rosenthal on the right side. And now you see that this is the lobule of the tumor, which is within the velum interpositum. And you just need to release it and get it out. And it was rather adherent to all the surrounding structures. Here is the arachnoid membrane of the anterior part of the ambient cistern. Now we are getting underneath the tumor, exposing the quadrigeminal plate, which is over here. Here is one vein which should be preserved, the cerebellomedullary, cerebellomesencephalic vein, tiny, and in the midline, but usually shifted by the tumor to the opposite side, so you can resect it. Lots of veins here on the left side, lots of arteries directly attached to the tumor. So there was a really rather long surgery and rather difficult surgery. The left side by now is free. This is the opening of the third ventricle from posterior, and you see the tiny arteries being very attached to the tumor. This is the internal cerebral vein on the left side. So one should be all the time aware what is what. This is the left Rosenthal vein. And this is after the resection, the Rosenthal vein on the left, opening to the third ventricle. These are both internal cerebral veins, and all the pineal region is rather free. This is after surgery, the radical resection. This is again the combination of approaches, but now we are not going to go downwards like in the case of petroclival meningioma, but upwards. We just started along the falcotentorial route to resect the part of the tumor which was extradural underneath the occipit lobe. You just release the tentorium, falx, and piece of the straight sinus. After this, I open the opposite side supratentorial just to make sure that I have a good control of the rectus sinus and tentorium on this side. You see that here the tumor is within the rectus sinus. After this and after cutting both tentorial edges, the straight sinus, which is occluded, is cut. Just thus you release the supratentorial compartment of the tumor in a way. And then we turn down underneath the tentorium, and this is the portion of the tumor which is infratentorially. And what I made a mistake was that the inferior sagittal sinus was the only drainage system of the deep veins. The flow was reversed, and the blood flew anteriorly. And here at the end, I'm cutting the inferior sagittal sinus with the remnants of the tumor between the hemispheres. And this disruption of the venous outflow, which must not have been, couldn't have been exclusive, caused really rather, we call it stormy postoperative course, and this is the end of surgery. This is after you see that all the dural structures are missing, the tumor is completely resected, but really the postoperative course was difficult. We are going lateral and inferior. It means we are going to CC junction. There are the tumors which are in the CC junction, jugular foramen and condyle. These are difficult because the jugular foramen is a difficult location for surgeries, and of course clival tumors. there is a very nice classification by Bernard George of CC junction meningiomas as related to the vertebral artery. It's nice, you can divide the tumors, you can discuss whether those which are below the artery are truly CC junction or spinal tumors. Sorry for the phone. But actually, the tumors are very uniform in a way. The anatomy is very uniform as well. You have the 9th and 11th, 12th, and the brainstem. This is the Roton's image, vertebral artery and spica, nothing else here. And system-wise, you have cerebellomedullary system, which contains the 9th and 11th. You have the medullary system, which is very ill-defined between this cerebellomedullary, and you have anterior spinal system. Be aware of this. These are the 9th and 11th and 12th on the dissection, and again, the outer plane of the arachnoid gives you a good plane of dissection. In larger tumors, you must realize that here is the division between the cerebellomedullary and cerebellopontine system, which is sometimes well-defined, but most frequently not. The dangerous structures are not the vertebrae. Those are huge structures which you always have, but the anterior spinal. Fortunately, these anterior spinal and all smaller are behind from the view of point of 7 behind the vertebral artery. So it's very unlikely. They are also well covered by arachnoid that you may damage them, but damaging any of these arteries may cause really catastrophic consequences. Again, part of the nerves are not really well covered by the arachnoid, and here it's in a practical way. This was the origin of the tumor. This is the 12th, and here is the outer arachnoid of cerebellopontine system, which really functioned as a wall against the tumor. We preserved this and resected the tumor very easily and nicely. These are the spinal tumors. Those are not the CC junction. These are the jugular foramen tumors, clival tumor. I'm not calling them midline because as of yet, I didn't see the true midline and only midline meningioma. There is always some side preponderance, which always gives you some access to the tumor. They secondarily grow into the foramen magnum, but actually the structures there are exactly the same. So foramen magnum or CC junction and the surrounding, this was the easiest tumors I ever have seen. This is the whole tumor and not a big one in cisterna magna, very easily resected from midline approach. Here is a CC junction where the arteries are above the tumor, but the opposite is true. The tumor is above the artery. It means that it grows from the region of the condyle. This is the surgical position. As we do it, again, microscope, exoscope doesn't matter. You are in a comfortable position and you do not need to stretch your hands. And this is one of the tumors to show you the video. I do not deal of the condyle too much. It's not really necessary. I'm not a friend of those extreme lateral, transcondylar and whatever, because you can do your job from below of the condyle and from above the condyle. You do not, it doesn't hinder you. If the approach is from the opposite side a bit, then you see the 12th nerve, which is very important here and should be dissected free as soon as possible. You can see it from very good angle. This is after surgery, you see the 11th, you see the 12th, and you see the condyle, which is not really that much resected. Still, your lateral approach is very nice, and it's given by the slope of the dissected muscle. A little more difficult tumor or larger, but still it's a uniform approach. You see finding the 11th nerve on the surface, then dissecting it free. The tumor is going low below the vertebral arteries. This is the same nerve, the 11th above the tumor. Then the tumor is released from the brainstem and devascularized, then piecemeal resected. Here we are underneath this is the vertebral artery, and this is the tumor origin over here. And the tumor grows even inferiorly to the vertebral artery, which is not really a big deal to dissect. This was the only CC junction tumor where it was adherent to the brainstem. You see that there is even a tiny artery. And this was the most difficult part. It was releasing the 12th from the tumor. And with some patience and piecemeal resection, we were able to do it without any consequences. Why do I not see the condyle that severely? This is the largest ever resection I did. You can do your work from above and from below, and you get your axis of approach given by the tumor. The tumor provides the space, so you easily get to the opposite side without any manipulation with the brainstem, which is still nearly invisible for you. So this is sufficient, and you can go from above the condyle, from below the condyle, doing your job properly. This is a curious case with symmetrical bilateral meningioma. Another curious case where there was a CC meningioma, a large one, and a small acoustic tumor. We did it stepwise. From the left side, the meningioma, and then from the right side, the schwannoma. The patient had a very, very difficult postoperative course after the meningioma. That was the only case where we needed to perform tracheostomy and PEC for a while. And only when she recovered, we did the schwannoma, and the young lady is doing well. Again, the dog with the same CC junction meningioma and with the same far lateral approach in a way. And this is just to conclude the skull-based meningioma. This is the region of risks. These tumors which are posteriorly to the red line are rather easy. So it's going from posterior clinoids, posterior to the fifth nerve, posterior to internal acoustic meatus, posterior to the jugular foramen, posterior to the hypoglossal canal, and along the anterior rim of the CC junction. So this is the region where you may expect some complications, and although where there is a risk of death of the patient. In my mind, the questionable location is the posterior clinoid meningioma. It's posterior to the Lillienquist membrane, which delineates the posterior fossa. The arteries are anterior to the tumor. So it's not really that logical to come from above, from the pterional approach. See, these two posterior clinoid process meningiomas. This one, of course, is a small one, and it's easy to approach it from above. And even if the arteries are in front of the tumor and the third nerve pushed anteriorly, you still can manage. Not in these large ones. This one I did by supra-infra approach, and I was able to resect everything except for the cavernous sinus. So probably the posterior clinoid process meningiomas should be included into the posterior fossa tumors, despite the fact that they grow primarily supratentorially. Then there are this orbitosphenopetrocliver. You see it in the orbit, in the sphenoid, in the cavernous sinus, and in the petroclival region. So where should we put this tumor in classification? Another tumor coming from CC junction, going up, you get into the CP angle, then going up, you end up in cavernous sinus, then you get along the sphenoid wing, so you get wing meningioma, and going even further, you end up with the planum sphenoidale tumor. Another one like this, planum sphenoidale petroclival region. So these are the tumors which are almost impossible to classify. This is my hobby, the beetles, and some of you are from Japan, where it's very popular too. I've got this beetle in Mexico. It's called Beneshi. A friend of mine has described it, and it's really well defined and well distinct species from all the others. So the name is perfect. On the other hand, this one from China, from high mountains, was first described as Ecoptolabrus beneshi. All right, then it was revised, and suddenly it was discovered that it belongs into the exigos, that it's only subspecies. Now it's named after my wife. So in taxonomy, in most of zoology now, these species which are not really well defined and belong to some other, they are the groups. They are made like groups, and we should probably have group like that in Meningiomas. You see that international zoological nomenclature acknowledges only genus and species, nothing more. So going from the kingdom of tumors to order of Meningiomas, genus of sphenoid wing, we get to these three species, excuse me, lateral, middle, and medial. But then we, of course, as neurosurgeons, and to compare the series and to really talk about the complications related to some specific tumor, we need subspecies like Arachnoid, sphenoorbital, and these. We need aberrations, forms, variations, which are in zoological nomenclature as well. Say anterior Arachnoid may be medial, and this one will be small, and it's causing symptoms very early on because it pushes on the optic nerve. And if it's a millimeter or two to the side laterally, it grows into the much larger volume because it doesn't cause any symptoms. So we need to have these variations as well. And then we would end up with cavernous sinus group, petrous apex group, and like that. This is the key to determination of animals. You know, you go from one paragraph to the other. In Meningiomas, it would be like first paragraph, supratentorial. All right, supratentorial, let's go to the point number 4. It's convexity, yes, it's convexity. So let's go to number 9. Parasagittal, of course, we go for 14, it's unilateral. And in this way, all the meningiomas could be really easy for determinations, but I'm afraid that this would not go through with neurosurgeons. So should we do it once, we shall publish it in Zootax and not in neurosurgical literature. So to conclude the talk, there is the general management at the beginning. Surgery, radiosurgery, radiation, or as a legitimate policy observation to decide. If you have decided wrongly, you only know with the hindsight. That happens, that's avoidable. In conclusion, it's most rewarding surgery because you really cure your patient should you perform Simpson 1 or 2 resection. It's also dangerous surgery because there are many patients which are asymptomatic coming to us. You hit your head, you have your CT in local hospital, and you go to our department with your meningioma about which you didn't know anything. Thus, the morbidity is serious, especially in scalp base along that famous U-shape sinuses. What I now do, that I offer surgery only to those where I can prove growth or where the symptoms appear. Rather frequently, patient is a lady, 50, 55, who is treated by her gynecologist with hormonal treatment because she wants to be younger and more beautiful, and she has diplopia. If you take the hormonal treatment away from her, she will definitely improve. She will become asymptomatic, and she can have her tumor for another 20 years untouched because it doesn't grow. Or you can treat it with radiosurgery just to arrest the growth. So it's very difficult and very, let's say, important to decide for the mode of treatment. Of course, remnant is better than the deficit. You have seen those 2 patients where I have left piece of the tumor on the brainstem, and both these patients are doing perfectly well. They are without any deficit. Consider all the alternative treatments, as I have said. And observation, and I repeat it again, it's a legitimate treatment modality in meningioma. So in this management complications, you know, you only see with the hindsight. You do not know it in advance, which is unfortunate. Then we have the complications related to techniques, which is cranial nerves, vascular, and neural. It's obvious, unavoidable, you will have your complications. My old boss was saying, if you see the third nerve, you already caused the palsy to the third nerve. And it's somehow true. And then we see the patients where complications are almost unavoidable. I call them too much too late. That is the patient who is 80, 85, who's got a large meningioma in CP angle, and who's deteriorating clinically. You cannot decline surgery, but you cannot expect a good result. It's really difficult to treat these fragile patients who are after 5 bypasses. They have their arteriosclerosis, they have the problems with breathing, they have diabetes, whatever you name it, and they have a huge posterior fossa tumor. Much too late, but cannot decline. Of all this, what I have told you, I would stress again anatomy, anatomy, and anatomy. That's the most important part. And you see it here with Hyperion, who is showing this huge abstract painting called internal carotid artery anatomy. And this was presented at Museum of Modern Art in New York in 2019. It's beautiful, isn't it? All right, Mr. Chairman, do I have 5 minutes to present Czech Republic or not?
Yes, you may.
Few minutes. All right, so let me tell you, since you are from far, far away and in different time zone and from large countries, we are a small country of 2 million inhabitants, squeezed between Poland, Germany, Austria, and Slovakia, just in the middle of Europe, in the center of Europe. The capital is Prague, which definitely is the most beautiful city in the world. And you never get bored there. There's more than 100 theaters, lots of concerts, exhibition, large expatriate community, perfect place for living. Our university is the oldest one north of Alps. The only older ones were in Italy and Oxford and Cambridge in England, nothing else. And it's really very old, founded in 1348 by King Charles IV, who was like father of the land. There were 2 important guys working at this university. It was Hans Chiari, who described his malformation in Prague, and Purkinje with his cells in the cerebellum. Then you may know Franz Kafka, who was born and lived in Prague. You may know Albert Einstein, who lived in Prague for quite a long time, actually in a house where one of my colleagues now lives, not in the same apartment, but very close. And Wolfgang Amadeus Mozart, actually, Don Giovanni was first performed in Prague. We have these 2 big sportsmen in our history. In Olympics and Helsinki in 1952, this guy, Emil Zátopek, won 5,000, 10,000 and marathon. Never ever anyone else was able to do that. And this lady got 7 gold medals in gymnastics. That was at the times when it was not by the children, but by the adults. There are many other cities in the country which are medieval and beautiful sites. Many chateaus and castles all over the country, many spas. It looks like we are not working, but we do. The country is very green and it's not flat. We do not have high mountains, but we do not have flat land, which is just excellent for living. We have, of course, seasons, so now it's rather cold. We love football, but we are not good at it, but we are good at ice hockey. And that's the fastest game. The American football is a rather gentle and slow game compared to ice hockey. It's played with this small little puck, you know, which is of hard. Anyway, national pastime is skiing. Everybody in the country is skiing. It's like crowded, all the slopes in the country. These are the 2 famous tennis players, Ivan Lendl and Martina Navrátilová, both of them Czech. This Czech lady was several weeks #1 in tennis. This lady, Kvitová, she won Wimbledon twice. This one goes for 10 years in top 10. We are going to industry, cars. Automotive in our country is some 40% of GNP. This is Škoda Autos, which is part of Volkswagen Group, but many other cars are produced and many parts. We are doing brakes and mufflers for all 3 major German companies. We are extremely good at weapons, tanks, subsonic fighters, but especially handguns. Company producing this revolver just now bought the American Colt company, the most famous handgun company in the world. And we produce Semtex. In the communist time, all terrorists from all over the world were shopping like crazy. Glass is one of our best imports. This is the late Shah Pahlavi from Iran, Palace, and all the glassware and everything is from Czech Republic, especially Middle East. They are the best customers. In the Siècle Arts, Alphonse Mucha was one of those who really promoted this part. And we are producing this Petrov pianos, which are on a par with Steinway, one of the three big and the best companies. The cuisine, it's unhealthy. You would get a ham roll at the beginning, then the tripe soup, duck leg with dumplings and kraut. After that, you will continue with extremely smelly cheese. It's really, you can eat it alone. You shouldn't be in a company of anyone else. And sweet drink will be crepes and the end of the food. But what's important is this. I don't mean disregard. We have plenty of beautiful girls in the country, but we have this beer. It's Pilsner beer, Pilsner Urquell. It's again mother of all beers. Still the best beer in the world. Pilsner, it's named after the Pilsen, the city 90 kilometers from Prague. And it's origin of the name of all the beers all over the world. Pils, you know, it's Pilsen. This is the place where the best beer is produced and where some of the best girls are living. All right. Thank you for your attention and thank you for listening about the country.
Sahara, you may kindly unmute your mic.
Yes. Thank you, Professor Venice. We could learn too much from your lectures, and I have a lot of questions, but time is limited. So first, I would like to ask you about the timing of gamma knife. You mentioned do not pass it in the gross total resection, and subtotal resection with adjuvant gamma knife surgery is superior to gross total resection you mentioned, I remember. So what timing is best for the gamma knife? You did gamma knife just after the surgery or wait and scan? Which is better?
I understand. I cannot say. There are two policies. One is upfront radiation that immediately as you have the remnant, you radiate the patient. The other is only when you prove the growth of the remnant. This is what we are doing. I don't know whether it's correct or not. So we are following the patient with a tumor remnant for a while. Should the remnant grow, only then we go ahead with gamma knife. And this probably should be based on the location of the remnant. If the remnant is located distant from the origin, let's say like adhered to the brainstem, then you may wait because it's more likely that the tumor will not grow. If the remnant of the tumor is where the tumor origin was, then probably upfront radiation would be sensible because it is the same place where from the tumor originated. But there is no literature about this.
Okay, thank you so much. Thank you so much. And second question, you usually do the supracerebral infratemporal approach to the petroclival region, and we Japanese neurosurgeons are not so familiar with this kind of approach because we don't familiar with sitting position, you know, as you know. So what do you think about this approach to the with supine or park bench position? Is it also acceptable or not?
This is the approach which really must be learned. It takes some time, and the best model disease for this approach, there are two. Pineal cyst, with which I have started a long time ago, and I was doing bilateral approach going along the vermis, which is not sensible. And the second is the trigeminal neuralgia, the neurovascular decompression. We do all our decompressions only by this approach because you just squeeze a cerebellum a bit and you get to the fifth nerve directly. You never move the nerve in the long axis as from retrosig. If you go from above, you just have it like a floating, you know, and you see much more. So these two are the best learning diseases for supra-infra approach. And suddenly you realize that you can reach a lot. Actually, I don't like retrosig that much. So anything which is above the internal acoustic meatus is suitable for supra-infra. Pontine cavernomas, you reach it very easily via supra-infra. You do not need retrosec. You go ahead with supra-infra. The prerequisite probably is the sitting position, because then you use the gravity for the brain. I've seen a supra-infra performed in a prone position several times. It's a disaster. No way. But in a sitting or semi-sitting position, then really the cerebellum falls down perfectly. Don't open the dura too low, because then the cerebral hemisphere would prolapse. Just keep it, make your lumbar drain, and suddenly you have the perfect vision from thalamus on the contralateral side to the CP angle on the same side, from internal acoustic meatus with temporal section up to mid-temporal, mid-occipital lobes. It's a it's external approach of the posterior fossa. Craniotomy is easy, fast, and very flexible.
Okay,
I really love
so
it.
much. Thank you so much. And last question, please allow me to give you a last question. And we Japanese love the anterior petrosal approach to the petroclive region, the so-called Kawase's approach during the anterior petrous apex. How do you think about this approach to the petroclive region?
Can I be frank? I don't like it.
Why?
I did it
Why
several
not?
times, and I use it for Petros apec chordomas. Then it's perfect and excellent. But going to the posterior fossa, it's far more difficult than supra-infra. The advantage is in Gasserian ganglion. This is much more easily reached from temporal fossa than from supra-infra approach, because then the ganglion is in the direct line of your side. So you do not have a good orientation there. But you can drill the Petros apex from supra-infra. Not easy, but you can do it. And by all means, these transpentrosal approaches mean retraction of the temporal lobe. So again, lumbar drain and all these maneuvers, but I really can tell you that I have used it in the distant past for several petroclival meningiomas. I was not happy.
Oh, really?
I was not happy. It takes time, dangerous. This is much more easier. You get there, you immediately see the brainstem if you got the tentorium. You have a very good control of 7 and 8s, which are below.
So you can go into the microscope also from the supra-infra.
You can.
Oh,
Not easy, but you can. You can.
Okay, thank you
And
so much.
You can easily go downwards. You know, with transpetrosal approaches, you end up at 7th, 8th. You do not reach the jugular foramen. But if you need it
quite
from supra-infra, you very easily switch to retrosec.
Okay, I understand. Thank you so much. So please, Raja Sensei, please. Yeah, thank you so
Thank
much.
you. Thank you very much, Professor Vladimir Venice and Professor Takayuki Hara. That was very interesting, and we learned a lot from you both. Thank you very much. May I also announce to our viewers that this has been broadcasted on YouTube, Zoom, and WeChat as well. And Professor Shubin has arranged a WeChat broadcast for this webinar today. And currently we have around 940 people who are viewing this live. So we are extremely grateful to Professor Shubin for this. And with that, we'll move on to the second session. And I would like to invite Professor Deepak Gupta, whose introduction we have already mentioned in the beginning of the webinar. Professor Gupta will say a short introduction about trauma care systems and invite Professor Masanobu Suda for his lecture. Professor Gupta, all yours.
Thank you, Dr. Raja. Greetings from India. At the outset, I want to thank Professor Vladimir Venice, who had notes way back in time. And whatever the pictures he showed of Prague, you know, it kind of refreshed my memory. And thank you, Dr. Venice, for teaching me those days. You can see something red on my forehead. I mean, we have a Diwali festival going on in India. It's a 5-day festival, and the festival began yesterday. So there are a lot of hustle and bustle going on in the city. It's a festival of Hindus celebrated by people from all community. So greetings from India to all the ACNS members and wishing you a very happy Diwali. Coming to the topic of trauma care systems and helicopter medicine, which my next esteemed speaker, Professor Tusuda, will be talking about. Well, way back in 2007, we from India, we went to Israel, to Haifa, Rambam Healthcare Center. And we kind of imbibed a trauma healthcare system model from there. And we kind of reciprocated the same in our country. And all I can tell you is that it was a game changer. So I am pretty convinced that the trauma outcomes can be significantly improved if you have a balanced trauma healthcare system in your country. Recently, Center TBI conducted a huge study of almost 30,000 patients, out of which 5,000 patients we had a core data of pre-hospital transport. And we had something like almost 2,000 plus patients who were shifted within 22 minutes of trauma. And this goes on to tell you that what is the relevance and the importance of pre-hospital care guidelines, the air ambulance systems. In fact, in the whole of Europe, Norway is one country where the ambulance services are at the maximum, if you compare it to the rest of the Europe. A lot of people are talking about the prevention of hypotension and hypoxia, though in the center TBI, we actually did not notice so much of hypotension and hypoxia as has been documented in the literature. There are a lot of issues and questions in the mind of everybody, including me, regarding traveling in about the cabin altitude pressure changes and the car practice, CAR practice, and other restrictions, whether you should fly at 8,000 feet or lower down. What is the association of hypoxia, hypobaria on the secondary traumatic injury? So I will not come between the viewers and Professor Kisuda. I hand over the stage to you and I look forward to your lecture.
Okay, thank you for introducing me, and I'm great honor to speak in this webinar. Okay, I'll start my webinar. Okay, so today I want to talk about trauma care system and helicopter emergency medical service in Japan. And I'm working at Aichi Medical University, Department of Emergency and Critical Medicine, and also in the Center of Disaster Medical Science. And I'm not a specialist of neurosurgeon, I'm a specialist in the trauma surgery. So my talk is not so interested in a neurosurgeon, but is very important for the trauma care. Okay, so our university is located in near Nagoya City. Nagoya is almost central in Japan, and our university is in Nagakute City, and next to Japan, next to Nagoya, and it's in the middle of Tokyo and Osaka, Kyoto. So in our university in this Aichi prefecture is population 7.5 million, and capital city is Nagoya. And is it the industrial prefecture? The gross domestic product is the second in Japan. And because that's the headquarters, Toyota Motors Corporation is located in that prefecture. So a lot of Toyota companies manufacturing in this prefecture. But still, we have a beautiful castle, beautiful shrine, and good food in Nagoya. So if you have a chance to come to Nagoya and Aichi Prefecture, please come to Japan, please visit Nagoya also. Okay, so our university's establishment is 1971. It's a private university, and we have a school of medicine and college of nursing. And hospital, we have a bed capacity is 900, and we have 22 clinical department and 2,400 outpatient per day. And the number of ambulances per year is almost 7,000. And we have also altitude emergency and critical care medical center. And we have a helicopter system from 2002. It's almost 20 years. And 2014, the main building is brand new. So it's a beautiful hospital. And this is our department. Okay, so let's talk about emergency system in Japan. So ambulances, we have 6,000 in Japan, and number of patients is almost 6 million per year, and it's grow up year by year. But this ambulance system is free in Japan, and public. It's all public ambulance, so that's why it's free. And phone number is 119, and licensed paramedics can administer fluid and medication depends on the situation, like witness CPA. But it's not like in the USA system. So the paramedics have to come to hospital as soon as possible because they can't do, so in case they can do an intubation, but not so much. So ambulance is almost made by Toyota, and this is not so large size because the road is not so narrow. Road is a lot in Japan, but it's enough to do something. We have the ambulance have a ventilator and monitor, AD and backboard, and some like infusion here. Okay, so trauma care in Japan. So we don't have a shock trauma center like United States, but we have an emergency and critical care center in Japan. We have 266 locations in Japan, and these center can treat the MI or stroke, CPA, severe trauma, and severe head injury. So like severe head injury or stroke patient will come to this center. And it was licensed by Ministry of Health, Labor and Welfare. And about 45 of this 166 is altitude emergency and critical care medical center. And this is Aichi Medical University is also this center, and we can treat extensive burn, poisoning, and amputation, limbs or fingers. So what is a trauma education in Japan? So this is a series of educational system, and we have JP Tech, JA Tech, and JE Tech. The target is different, and JP Tech is a pre-hospital, and JA Tech is for the all doctor physician, and JE Tech is for the trauma surgeon. So I'll talk a little about detail of this one. So pre-hospital is JP Tech for paramedics. And this one is based on the basic trauma life support BTLS in the United States and certified by the Japanese Association for Acute Medicine. And target is paramedics or nurse, almost it's paramedics. And in the essence of this JP Tech is do an initial assessment within 50 seconds. And the first paragraph of this one is cervical spine protection. So it was very important for the paramedics to keep a spine stable. And then second is in airway, third is breathing, and fourth is circulation. So in Japanese, paramedics will be very, very careful in spine protection. That's very good. And also the full body observation to be done within 2 minutes and 5 minutes accommodate. And if they found any abnormality in the assessment or general observation, there were indication for road and go. And road and go is, so trauma patient can only receive in the fundamental treatment at the hospital. So observation treatment of the non-life-threatening injury should be omitted, and only life-sustaining treatment should be performed. So that's, so these philosophies for the road and go, and so they should have to transport that one in a medical institution specialized in trauma treatment. So they will come to the emergency and critical care medical center. And also at these patients for spinal column immobilization is necessary. So they will use backboard to carry this patient, these patients. And then it was take over the JA Tech in the hospital. So this one is based on also an advanced trauma life support ATLS in the United States, and this one is to avoid the preventable trauma deaths. So in like 20 years ago, there are a lot of preventable trauma deaths in Japan. So an acute and Association of Acute Medicine person will think we have to do some course, like education course, and that's the reason. So this JTech was started in Japan, and this one is for all clinician and engaged in trauma care. So maybe a lot of neurosurgeons will learn this JTech in Japan also. So the preventable trauma death is death due to lack of a proper medical care and after trauma. And as long as we keep the area clear, or if only we had the notice that the tendon pneumotrax and deflated it, or if only we could stop the bleeding sooner. So this problem has happened. So in this JA Tech, it says any doctor could have saved with a procedure they could have performed. So it's not so difficult to do something in these patients, but to notice this problem is very difficult. So preventable thrombosis occurs in like 10 minutes to a few hours after trauma. And the JTEC says the recirculation in the first hour and after injury determines the patient prognosis. So in this part, the first step of the treatment is very, very important. So this lady has a face injury, and usually doctor interested in disorder of consciousness. This lady is also in the disorder of consciousness. So he think we need a CT first. So the patient come to the hospital and go to CT and they start scanning. But during the CT, the respiratory arrest occurs because she has an asphyxia. Because she's in a loss of consciousness and she has blood bleeding in the mouth, so she can't breathe anymore. So next patient, she had a leg injury, and so he begins the wound examination and focus on wound care because they have a little bleeding here. But eventually he went into shock and dead with intraabdominal hemorrhage. So he was just focusing the leg injury and he did not check other place. So this once happened. And this patient had an arm amputation and his level was clear first. So he said, it's hard to do something, and it was very hard pain. And after that, dyspnea appeared during the XP examination. So the doctor will intubate and place on the ventilator. So he needed an operation. So I think the doctors think the intubation and sedation is good for him. But eventually a sudden blood pressure, drop in the blood pressure and due to the tension pneumothorax. So he did not realize the pneumothorax and he would do the positive airway pressure and then was going to the tension pneumothorax. So if he realized this problem, we can avoid the preventable trauma death. So in the geriatric course, we call the ABCDE approach. This ABCD is very, very important. So A is for airway, and B is for breathing, C is for circulation, and D is for dysfunction of CNS, and E is exposure environmental control. So in JTEC approach, primary survey, that means the ABCD approach is very, very important. So if the ABCD is not stable, we can't go to the next treatment. So next treatment is a secondary survey. And if ABCD is stable, we can go to the whole body examination. And then finish the secondary survey, we can go to the curative treatment like operation. So the most important part is the ABCD approach, and we have to stabilize the ABC. So let's talk about detail of the A and B. So A is airway, and we have to consider the intubation. So can we continue with oxygen only, or does he need our intubation, or do we have to perform the emergency cricothyroid ligament puncture or incision? So we have to decide in an airway problem like this. So indication for the tracheal intubation is for apnea is abnormality of B, and inadequate airway clearance is A, and the possibility of aspiration is A, and airway narrowing due to the facial and neck injury is A, and disturbance of consciousness is D, and insufficient oxygenation is B, and severe shock is C. So the indication of the intubation is not only the problem of A and B. So D and C, in case we have to do an intubation. So abnormality is for very, very important for the neurosurgeon. So the difficulty is in C. So C is circulation, and we have to check response to after the initial infusion therapy. So if the blood pressure will be stable, we call this responders. And this patient, we can go to the secondary survey. But even in initial infusion, we have to keep a high volume of infusion, is the transient responders. And this patient, in case we have to do operation or IVR. But in the non-responder, this means that after the initial infusion, the blood pressure will not rise up. So in this patient, we can't do then secondary survey. We have to repeat the ABC, and we have to do something in this non-responder. In a lot of cases, we have to need an emergency operation, even in the ER. And also in the problem of the circulation, we have to think about bleeding in an MAP. So MAP is massive hemothorax, intra-abdominal hemorrhage, and peritoneal hemorrhage. This is important in the first step in ER. So that's why we have to do a fast and chest and pelvis X-ray. And we have to find this maximum bleeding, massive bleeding. And if not correct these, we have to repeat ABC and ABC and identify non-responders. If we can do that, so such a problem in the previous slide will not occur. So keep in mind during the primary survey is the cardiac tamponade is abnormality of C, and airway obstruction abnormality of A and B, and flared chest is B, open pneumothorax is B, so tension pneumothorax is A and B, B and C, and massive hemothorax in B and C, and the abnormal hemorrhage is C, and retroperitoneal hemorrhage is C, and severe head trauma is D. So,
愛は日本の歌手、ソングライターである。
sorry.
アメリカ合衆国。
Sorry. So D is dysfunction of shearness. So impending D, we have to be very careful. So what is impending D is less than JCS 8 point, and we call the JCS we were using in Japan, JCS more than 30, and degrees of level of consciousness and sign of brain herniation. So if we found these cases, we have to call the neurosurgeon and perform CT immediately. But it's start before the secondary survey. So that means we have to stabilize the ABC first. Even if the ABC is not stable, we can't go to the CD. And this one's Japan coma scale. It's very easy to understand. So in Japan, paramedics will use this one. So the 1-digit code is the patient is awake, and 2-digit code is can be aroused. So and digit 3 is cannot be aroused. So then paramedic says it's a JC3 3-digit code. So we realized that was in a severe coma. So next steps is E. E is exposure and environment control, and important is temperature management. So the infusion must be heated in 39 degrees. And if you use a blood transfusion, we have to use the level 1 or hotline. This one can heat the transfusion. And room temperature must be 28 to 30 degrees. And we have to use the body surface warming or blanket or something. So if in the low temperature, it should be very serious problem. And after JTEC, it was take over to JETEC. This was a specialty for the trauma surgeon. And this one is training in specialty care with focus on fundamental treatment based on the JTEC and clinician who specialize in trauma care. In the JETEC, it was focused in deadly triad. And this one is hypothermia, metabolic acidosis, and blood coagulation disorders. So if the patient is in a deadly triad, we can't continue the operation, and we have to do something to avoid this 3. So hypothermia is less than 34 degrees, and metabolic acidosis is less than 7.2, and blood coagulation disorders, prototomy time is less than 50% of normal. And also in JETEC, the damage control resuscitation is very important. And this one is in the 3-part in abbreviated surgery and hemostatic resuscitation and permissive hypertension. So abbreviated surgery is damage control surgery, and operation was finished within 60 to 90 minutes, and hemostatic resuscitation, the massive transfusion protocol, and we have to do a transfusion, RBC, FFAPC 12121, not only red blood cell. And also we have to do a permissive hypertension, and the systolic blood pressure was permitted in 90. But one point, this was a bit higher in head trauma, and it was age more than 70 years old. We have to keep 110. So that's so we have to keep the CCP in more than 60. So damage control surgery is abbreviated surgery. So this surgery, we can't finish. It's not curative operation. So the major bleeding vessel must be ligated, and we will use gauze packing and temporary suture with an automatic anastomosis machine, and the operation finished within 90 minutes. So after this abbreviated surgery, we have to avoid the dead retried and go to the intensive care and stabilize the ABC and avoid the dead retried. And if everything is clear, and then maybe next day or 78 hours later, we can go to plan the curative operation. So this patient is our patient is, she was in a severe intra-abdominal hemorrhage, and so we will do a gauze packing, and this one is ER, and we are using an Absera and do an open abdominal management. And next day we'll go into curative operation. So Absera is the negative pressure, or keep negative pressure in the sponges, and this one we can use in the hemorrhage also. So the most difficult part is how to stabilize the C. This is very, very difficult, but one answer is we are using Riboa. It's an occlusion balloon of aorta. And we have this one, the name is rescue balloon ER, and it has everything is in one set. And this Riboa is mainly placed in the aortic outer zone for the intra-abdominal bleeding in this area, and for zone 3 for the pelvic fracture or lower limb bleeding. This is very useful. So this one is treatment strategy in our department. And if the trauma patient comes, he was not in shock, we can do the JTEC strategy and primary survey. But if he's in shock and doing it fast as soon as possible, we can do it like 10 seconds or 15 seconds, or the potential for the massive bleeding in MAP. And maybe the patient is in impending cardiac arrest or cardiac arrest, we are doing emergency tracheotomy and doing L-tip clamps in ER. And if it's not impending cardiac arrest, we will stand by Riboa and use our DRCs, 4 or 5 French to femoral artery, and doing the infusion. If it's a responder, we can do the JTEC strategy or primary survey. And if it's not a responder or transit responder, we're doing operation at ER. Or in case we have to go to the operation room because like nursing is not enough in the ER or something, we will insert Riboa and save time and save heart and brain. And anyway, I'll do clamp. After that, the patient be stable, we will convert to Riboa. So Riboa is a little controversial treatment, but in our department, I think it's very good. And we can save, keep a time and keep a vital. So in severe trauma, avoid preventable trauma death is very important, and repeat ABC and ABC and ABC is very important, and consider damage control resuscitation. So this one's for the trauma care. So next, I want to talk about the helicopter medical system, Dr. Heli in Japan. So this is our helicopter. And the start we have in 1995, we have the Great Hanshin Aoji earthquake. So one is 7.3 magnitude earthquake in the west part of Japan, and this is the Kobe in this area, and this one's Japanese earthquake scale 7 is maximum in Japan. And the victim is more than 6,000. So in this earthquake, the Hanshin Express, the highways collapse, building, house, and this is building also collapse, and many people die. So this is a station, terminal station, and we can't see the first floor. So in this earthquake, delay in the initial medical system and also difficult to transport to non-disaster area. This one is too big problem in this disaster. and there may have been about 500 preventable disaster deaths in this earthquake. So after that, in Japan, so we make a team at this one's disaster medical assistant team. And this one team is in one hospital, maybe, and in the big hospitals, they have several teams, and doctor, nurse, and drivers. They have in one team and go to the disaster area by themselves. So this one is our hospital team, and we are doing it every year. And also difficult to transport to the non-disaster area. So we're developing the helicopter emergency services in Japan. And this one is Dr. Haley. So we have a similar system in other country. In US, it was started in 1970, German 1970, Switzerland is more faster in 1950, and France is 1980. I hear that Australia started in maybe 1920, and Japan is 2001. And the German is the similar size country. So the Dr. Hay will introduced by based on the German system. And German system, they have the 75 helicopter in radius is 50 kilometers. And Japan were now in the 54. So this one is German ADAC, and this one is Switzerland Rega, and this one is France SAMU, and this one the Air Method. And only US is and a private helicopter company will use this system. So in Japan, this is in Japan map, and we have in 47 prefecture and 45 has a helicopter. So Tokyo did not have, because they have a lot of hospital, but I hear that next year they have one helicopter in the Tokyo also. So the large size prefecture have several helicopters now, and it was 45 heli right now. And the dispatch per year is almost 30,000. And per machine, it costs 2.2 million per year. It's expensive, but $1 per capita. And cost per dispatch is $4,000. But the patient do not have to pay this one. And flight speed is more than 200 kilometers, and the ambulances are usually riding 80 kilometers, and even in highways 100 kilometers, so we can go faster than the ambulance. So this one is our helicopter. It's compact. It's almost 10 meters, and we can attend the 6 passenger, and 1 pilot, and 1 mechanic, and 1 doctor, clinician, and 1 flight nurse, and 1 patient. And we have 1 more seat, and in case the family will attend on, or an OJT doctor, OJT nurse will use the seat. And this is Aichi Prefecture, and almost at max, it was 70 kilometers from our university. So the Japan Dr. Haley has 5 different helicopters, and all helicopters, Airbus helicopter EC-135. And this one is in hospital, it's communication center, and he is communication specialist from the company, and he will check the weather or input the flight plan, or make a contact with fire department, or using the camera to see the weather condition. And this is the map, and we can reach it at 7 kilometers for almost 20 minutes. So after the accident, usually we can go there by 10 minutes or 15 minutes. So this is me, I'm in the countryside and waiting for the patient. So time numerical target of the Dr. Harry is to start treatment within 30 minutes from the fire department notification. So this reason is in the golden hour principle by Kara, and he said if it takes 30 minutes, massive bleeding, the arrest date is in 50%. So we have to start treatment within 30 minutes is a numerical target for the helicopter. So this one, I take this picture, and this one is a 2-car accident, and this one's also in 2-car accident. And this is patient is still in the car, and 1 patient is in the car, and 1 patient is start the treatment. I remember this patient was CPA. And also he's still in car and the rescue coming and pull up this car and try to rescue him. And we're waiting at outside of this area. And this one's also rescue and stabilize the car and try to keep out him from the car. And also we go to the golf course because golf course, elder man is in MI or stroke. And also we have a Lucas in the helicopter. It's very, very narrow system, but Lucas can work in this system. So if we don't use this Lucas, we can't do a good CPR because we have to do a seatbelt and it's far from the patient. So Lucas is very good for CPA patient. And the neurological emergencies, we have 91 case in the year. It was 23% from all patients. And the non-trauma case, the loss of consciousness is 11 cases. And in the trauma, brain contusion, traumatic SHAs is 90 cases, and acute subdural hematoma is 6 cases, and spinal cord injury is 10 cases. It's a lot of neurological emergency. So this one is inside the hospital. Sorry, it's Japanese. I'm sorry, this is not in the helicopter. This was in the ambulance. So we usually do the treatment, intubation, or then fluid infusion, or these kind of treatment in the ambulance because more it's easy to access to the patient. So what I'm doing is I'm doing the tracheotomy and trying aortic clamp. So he become the CPA. We make a contact with him maybe 3 to 5 minutes. So that's why I try to do the aortic clamp. He has a severe abdominal injury. And after clamping, he was lost, and I will take back to the hospital, but it was difficult to save him. Okay, this is the final part. I will talk about ACN in Japan. We call HelpNet and DecodeNet. So now the Japanese car have a sensor of the collision, and so the sensor will automatically detect the collision of direction and severity. And this one uses a mobile telephone network and automatically report to the connection agency. And operator will answer to call back this car. And if the patient will not respond, or they say we need help, we need an ambulance, so the operator called to the fire department, and also they call to the air ambulance, that means Dr. Harry. So we have this is in a system in the front of the car, front top of the car, or in the navigation system. So usually if the accident happened, we can start medication in 38 minutes. But if we use this system, the accident happened, and we can start treatment in 21 minutes because the fire department notification and attached to the patient, it takes 15 minutes, and then they call the air rescue usually. But we save this time, and we save in the first step. So total 70 minutes, we can decrease the time. This was very, very important for the hemorrhage person in severe shock. So this one is called come to my cell phone, and I identify the accident will happen. And if I click this one, so the location, detailed location is on this second page, and the car type, and how about seatbelt, how many passengers, how fast it crashed, and how about the airbag. And this 30% is calculated severity. So this one, we consider the maybe in the driver's seat patient is severe, but then in the passenger seat, it's not so severe. And now the Toyota start this system, and all Toyota car, Lexus car have this one, and Honda is also have this system. And Subaru and Nissan, the Mazda vehicle will be newly equipped. So in all Japan, car has this system from now, but not in other country cars. So this company will try to contact with other country car bands or BMW, Porsche. They don't have it. So this one's the last. This one is dispatch of helicopter. So we have a doctor car. This one is, we can go to the accident site by car also. But we use this one to the heliport. So it's not so far from the hospital. It's just only take 300 meters. And helicopter is already standby outside. He's a doctor and he's flight nurse. And the mechanic will check the outside of the helicopter. Sorry. So from the fire department, for the takeoff time, it should be within 5 minutes. They go to landing point. And this one's the last slide. They come back to the hospital. So helicopter is very dangerous, so we are waiting for stop the rotor. So after they stop, we open the bag hatch and the patient will pull out from this back hatch. So he was stabilized with backboard. So this one is a hospital ambulance. And then they go to hospital. So that's all for my slides. And thank you for listening my webinar.
Thank you.
Thank you, Dr. Tsuda, for a wonderful introduction to how the trauma healthcare system or the trauma system runs. and talking about this heli services in Japan. I'm really impressed with your talk and with the kind of care you are providing in your country. Very impressive. I have a few questions for you. What height do you fly your helipad? Is it standard 8,000 feet or lower?
No, so in our prefecture, we don't have so high mountain, and usually it's almost 1,000 feet. So we don't have to care about the air pressure. But in some prefecture, they will go up to more than maybe 4,000 feet or something. So at that prefecture, they will be very careful.
Second question to you regarding your pre-hospital guidelines for the paramedics. Do you have a standard pre-hospital guidelines in Japan, and how much is the adherence or the acceptance of those pre-hospital guidelines?
So you mean the pre-hospital guidelines?
Yes.
I don't think we have it, this one, but a lot of paramedics know about this JP Tech. So this one is almost guideline. It's similar, almost the guidelines for the paramedics. But mostly the fire department decided the protocol. So it was based on, I think, JP Tech, but it's different in the different fire department.
One query I had, like recently in our country, we had a law, kind of, it was made mandatory that all cars should have a minimum number of airbags. Do you have something like this in Japan? Like all cars should have minimum of 2, 4, or 6 airbags? And what are the kind of sensors you are using in your country? Is it a law in Japan?
No, not in law. So we don't have in every car.
Okay. One last question to you. Do you have something like a trauma quality improvement system? Like how do you assess your trauma system in your country?
Okay. So yes, we have this system, and we have to. So in we have to input this severity or how to treat and the outcome of the patient. We have this system, but not every hospital input this system. So that's a big problem. So if every hospital can input, we can detect the preventable trauma best. But now only like the expert hospital will input this system.
Thank you. Congratulations once again. I hand over to Dr. Raja to take it further.
Thank you very much.
Thank you very much, Professor Masanabu Sudha and Professor Deepak Gupta, for that very interesting session about trauma care facilities in Japan. We are really impressed with the kind of facilities that the government provides you. It is indeed an eye-opener for the rest of the countries to follow. I have been there to your center, IG Medical Center, and I have seen that Dr. Heli operate, and we were really lucky to have a very beautiful place. Thank you very much. Are there any questions? Dr. Liu Bun Singh, would you like to comment?
Yeah, thanks, Raja. Thank you, Professor, for a very nice presentation. I have two questions, Professor, regarding damage control surgery. Is it performed by a trauma surgeon or trauma physician in Japan? Second question, Professor, regarding the contact with the car, the call. Do you have any integration with nowadays with smartwatch, which can monitor saturation and heartbeat to identify those high-risk patients? Thank you, Professor.
Sorry, please say it again.
The second question is whether there's any form of integration with smartwatch, because nowadays smartwatch can monitor saturation, heart rate, so to identify patient with a critical situation rather than just communication through the call in the car system. Are you going to have such facilities to identify, to integrate monitoring in all patients? Because nowadays people are wearing smartwatch that can have monitoring saturation, heart rate continuously. So that is one. Second thing is about damage control surgery. Is in Japan is open to all physicians or only trauma surgeon? whether emergency physician can perform damage control surgery or only trauma surgeon. Thank you.
Okay, so first question, I hope we have the system, but not now in Japan. And also in the trauma, I think the trauma surgeon can only perform the abbreviated surgery. But some surgeon can do that, but not in common, right? Still not common.
Conclude this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito. I would like to sincerely thank both the speakers of today, Professor Vladimir Venice and Professor Masanobu Suda, as well as the chairs, Professor Takayuki Hara and Professor Deepak Gupta, for their time and support for the educational initiatives of the ACNS. A special thanks to Professor Shubin for supporting us in our educational ventures, as well as broadcasting these webinars in China. Today we have around 940 participants watching us live on all three platforms, which are Zoom, YouTube, and WeChat. A special thanks to my co-host, Dr. Liu Boon Seng, also for joining today. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you very much for joining.